morning. My name is David Min. I'm one of the medical chief residents here at the University of Washington, and it's my pleasure to welcome you to the Department of Medicine Grand Rounds. Today, Dr. Sue Taylor from Group Health, the District Medical Director, will be introducing our speaker this morning. Dr. Taylor?
Thank you. Good morning. It is a pleasure to be here. Thank you all so much for coming. Yes, I went to medical school here in 1986. Idaho whammy, so all you affiliates, special greeting. Thank you so much. It's incredible to be a part of the University of Washington, and I have a special message for those of you who take care of group health patients, indeed patients in this city and this community and state. Thank you. You do an amazing job, and when they come back from their stay at the University of Washington, they talk about you, and not just the excellence and the innovation and the genius. They talk about your compassion and your kindness. I'm really grateful. The University of Washington is an amazing place to be, to learn how to give good news, right? It's thrilling to be able to say, your cancer is in remission. We fixed your heart. You can go home now. But the university has also been a place where they've learned how to teach people to give bad news when it's time to say, things haven't turned out the way we hoped. The cancer has returned. We need to set other goals now. Stu Farber started a palliative care program inpatient when nobody else was doing it. Anybody here ever rounded with him? It's remarkable. Randy Curtis at the Harborview Critical Care has gone to places to reduce stress, anxiety, post-traumatic events, not only for families and patients, but for doctors and nurses as well. Now that's cutting edge. You learn that that's just as essential as knowing how to do a thoracentesis, right? And the equipment you need is right there. It's that chair. Pull that up to a bedside. That wonderful place. Learn how to talk to people. One doctor at a time. I hope today somebody hears the call. Hope one of you makes that commitment to learn how to listen better. And to help us understand how to do that and why, we have an amazing speaker, Dr. Robert Martensen, Harvard, Dartmouth, UCSF ER doctor, PhD in history, bioethicist, now at the NIH, author of A Life Worth Living, a book you really have to read. But most importantly, he is the father of twin sons who play Preston and Porter on Desperate Housewives. Look it up. Please give a warm, warm Seattle welcome to Dr. Robert Martensen.
Well, thank you, Sue, for a generous introduction and the biographical family detail. And also to Dr. Farber for having a hand, I'm sure, in arranging this opportunity to talk with you. Our subject today, it's called palliative care. Palliative care became a recognized specialty in 2007, so that's quite new. But the concepts behind it, I think, are really good doctoring, and it's good doctoring for people in life's last chapter who have been living with serious chronic conditions and diseases. So today I want to start by, I basically want to make a tight, logical case, and then I hope we have time for lively discussion, why the palliative approach is appropriate for certain patients. This just lets you know I don't have any financial COIs in my affiliations. I didn't put on here, I'm speaking personally. The views I'm expressing are not necessarily those of the NIH or the US government. So I want to start by really talking about what it means to be a healer in social terms. What is the basis of medicine's social contract? Why do we enjoy our privileges in many societies, whether there's an organized medical profession or not? If you go back in history, as far as one can go and look at records, the person who functioned as the healer in a tribe was the first person to be released from the obligation to procure food. In other words, there is a kind of transcultural, almost transhistorical social value for the healer. Well, what does the healer do? What do physicians do and nurses do? I think the basis of our social contract is providing, in addition to technical competencies, sound judgments in the face of the uncertainties of human disease. That definition has been adapted from Richard Horton, who's editor of The Lancet. So what are the goals of providing these sound judgments and technical skills? To prevent, cure, and treat disease for the purpose of relieving its burden and the suffering associated with it for individuals and groups. And I'll be coming back to sound judgments a few times in this talk. When I look at almost any subject, whether it's as a practicing, I'm an ER doc by training and did it for many years in urban places like Harborview, to an historical or ethical subject, to even an administrative challenge, what I try to do is assess the relevant facts and factors, the values involved in each party, the interests and loyalties of the various parties. It's particularly valuable in doing history. And the voices, whose voice is present, whose voice is smothered, whose voice is authentic, and so forth. Because I'm trying to determine what's at stake, how to value these different things, what has oomph. And of course, one of the things that can sometimes cloud our understanding is we all know what statistical significance means, and we're so alert to determining p-values and so forth. But sometimes those aren't associated at all with clinical significance or the oomph factor. So in this presentation this morning, I want to first talk about some realities of suffering in the United States today as it compares in the world for people living near the end of life in their last 2 years with serious chronic problems, and raise the question, are we providing them with sound judgments? Are we living up to our social contract? Then I want to talk, how does palliative care work? What's involved with it? And then I want to suggest what a palliative care curriculum can look like. So when we think about suffering, obviously we're all trying to relieve it. We behave with mindful compassion. These lines come from Eric Cassell, who wrote them quite in 1982, but they've been widely circulated, and I think they're very applicable. Because we also, in trying to relieve suffering, we often create suffering. We do it thinking it's temporary, and we're doing it for a better purpose that the patients will recover. This slide is probably the next two are probably the most important I'm going to show you. This is commonly available data that has been assembled in a graphic form. And this shows what we do compared to other countries. The bottom lines follow EU countries, and the Japanese are similar to the bottom lines in the curve. And it's pretty straightforward, but it shows that in the US, particularly for patients over age 75, this is in terms of cost, but you can translate that into what do we do? What does the medical system do in terms of providing interventions, both diagnostic and therapeutic? Well, you can see if you looked from an economic point of view, you would find, looking at this graph, why the United States spends twice as much as any other country on health care. We're very similar, and then we go off into the stratosphere. But I'm not here to talk about economics. I'm here to hone to this idea of our professional social contract. We're really patient advocates, and our goal of ameliorating and preventing suffering. This slide, I think, may surprise some of you, because we think when we look at average life expectancy over the last 100 years, it's increased dramatically. From the mid-40s in 1900 to the mid-70s and mid-80s, depending on which country one's going in. But if we look at life expectancy for people who are already 80, how much has it changed in 400 years? Well, it's an unusual question, but a Swiss demographer asked it, and he used good life records from Germany, and noticed that if you were 80 years old in Berlin in 1600, 400 years ago, you lived on average to 86. Almost 400 years later, 80-year-old women live to age 88. So 2 more years for 400 years of medical progress. Now, what are those 2 years like? You can look under the curve. Well, we're certainly providing lots more medical care. Are we providing more longevity? Are people spending their last 2 years, for discussion purposes, healthy, happy, maximizing comfort function, in addition to having the extra 2 years? Or are they experiencing, in many cases, quite a bit of suffering? So what is palliative care? Many of you may have heard this. One aspect to emphasize is interdisciplinary. Interdisciplinary between specialties in medicine and interdisciplinary across healthcare services. Social workers are part of the picture. Nurses are essential to the picture. Nurses always know more about the patient's and family's experience. They're trained in illness experience. We're trained in disease treatment. Pastoral care is frequently involved. And the other main point is that unlike the part of palliative care that is hospice, palliative care, non-hospice palliative care, is not prognosis dependent. In other words, it's provided while one is providing treatments that may be curative. How does Medicare define palliative care? Well, they do it in very similar terms. It's through the continuum of serious illness. It addresses broadly physical, intellectual, emotional, social, and spiritual needs. And it's an attempt, again, to modulate suffering. At the core of the root of the word patient in Latin is to bear up, to endure suffering, to be resilient. And I find this line from Helen Keller inspirational in that sense. And Asimov is somebody I read as a kid, so I thought I'd put this in. Where does life end for most people in the U.S. right now? Well, about half of us die in hospitals. So where are all these final chapters playing out? A quarter in nursing homes and the remainder at home. What do patients say they want? Well, this is a large-scale study from about 10 years ago. Patients with late-stage illness say they want their symptoms managed, particularly pain, but not just pain. They want to avoid inappropriate prolongation of dying. They want to have some sense of control. And they want to not be a burden on their families, both a care burden and a financial burden. As we know, end-of-life care, as I've shown you on that graph, is very expensive. The people providing it expect to be paid. Medicare doesn't pay 100%. And the financial consequences of this very expensive, intense care that we provide is often financial devastation for the survivors. And people want to strengthen relationships with their loved ones. What do they experience? What are we providing with our sound judgments and all this care? Well, this was a well-done study of 9,000 patients from a while back, and it found that over half had severe pain in the last 3 days of their life. Subsequent studies have suggested that these numbers haven't bumped much. Now, this surprises me because during my practice career, I went to med school in the 70s. Since that time, the roots, the understanding of narcotics, of opiates, and the roots of administration have really multiplied. So we have very sophisticated ways, compared to when I started, of delivering opiates. Now, opiates have been around for a couple thousand years in medicine, but the sophistication has really grown in my practice life. Nonetheless, lots of people experiencing pain. And you could say, well, when somebody's coming into the hospital, we're so busy, we're doing all this stuff, there's a diagnostic flurry. First couple days, we might miss attending to their pain, that aspect of care. This, I think, is quite sobering. 5,000 patients after they've been in the hospital a week. We should know our patients after a week. A majority with these problems, colon and lung cancer, liver failure, multisystem organ failure, experience moderate to severe pain. So we're not quite meeting step one, manage my symptom and pain control. And of those in the previous slide who died in the study, about 40% spent more than 10 days in an ICU, in a coma, or on a ventilator. Now, if we look at Dartmouth Health Atlas things, we find that Seattle, in terms of end-of-life length of stay in hospital and ICU on ventilators and so forth, compares very favorably with other parts of the country. In other words, there's a great deal of regional variation. And one of the challenges is that even in some institutions with very well-regarded, well-established specialty palliative care services, when you look at these kind of metrics, length of stay in ICU prior to death, time on ventilator, and so forth, those hospitals also have the longest lengths of stay, time on ventilators, and so forth. So there is a disconnect in getting palliative approaches from a specialty consultation service into the idea of good doctoring in end-of-life care across a hospital. We tend to think dyadically in medicine. We are doctors, we have a patient, the patient may have a partner, but I want to broaden for discussion purposes that serious illness affects everyone in a family. We don't often think about family caregivers. The numbers are huge, roughly 35 million in 2006, doing it kind of a half-time job, around 20 hours a week, with a seriously ill relative. Who are these people? Most are women. Most have full-time jobs. A third of them are over 65 and not in good health themselves. So this is an enormous stress. As those of you who've lived through it in a personal family situation or been around the beds and dealt with family members would know. And of course, what do they say they want? They want to have the patient's wishes honored. Now, often families fracture, and finding out, hearing from different members, what does a grandma want, can be a challenge. They want to be included in the decision-making process. Also a challenge, many of them come in at different times during the day. They talk to the night shift, not the day shift. They talk to one specialist, not another. It's a challenge. They want practical things at home, transportation, medicines, equipment. The insurance reimbursement mechanisms in the United States are not well set up to provide that. They want honest information, a little bit of sense of privacy, not a hallway discussion. And they want to be contacted after the death of the loved one. And I don't know what UW does in this regard, but in many hospitals, the only notice you get after someone has died in your family is the bill. And the bill is 25 pages. It's many, many thousands of dollars typically, and it's incomprehensible. It's frequently full of errors from an accounting point of view, according to studies, and the language can only be understood by Medicare-friendly computers, because that's what the bill is designed to be interpreted by. Is that mindful compassion? Caregiving carries risk with the family members. A spouse faces substantial mortality risk. This looked at two measures: risk of a heart attack, 1.8 relative risk if they're doing it more than 9 hours a week. And if they feel stressed out, if they report emotional strain, an increased risk of death from all causes of 1.6 compared to controls. When we look at end of life and we're doing all these services, I've been kind of suggesting that more is probably not better. More medical care, more procedures, both diagnostic and therapeutic, more prolonged ICU stays leads to a lower satisfaction with care. It also leads to a higher mortality risk. This is a Dartmouth Health Atlas data, but regions of highest spending, most specialist visits, hospital stays, ICU use have the highest mortality risk in risk-adjusted and demographically adjusted populations. I don't know how many of you are familiar with the Dartmouth Health Atlas maps? All of you? Yeah, well, you can see the country, you find mountains where you didn't expect them. South Florida, in its normal topography, is pretty flat, but if you go to Boca Raton on the Dartmouth map, it looks like Mount Everest. Why? Because Boca Raton, Florida, which is an affluent retirement enclave, has the highest density of specialists in the United States, I think in the world. If you go to Pierre, South Dakota, which is at a considerably higher plane elevation geographically, it's very flat. Pierre, South Dakota has the lowest density of specialists compared to primary care providers in the U.S. and a low density of ICU beds and so forth. Nonetheless, where do people live longer on an adjusted population comparison basis? Where they're putting on heaters for engine blocks in the winter in Pierre, South Dakota, not in Boca Raton. The Boca Raton people have nicer tans, but they don't do as well. So what do family members report in these high-intensity hospital service areas? Less emotional support, less of a sense of shared decision-making, less information about what to expect, and less respectful treatment. And when you think about it, I think this is quite plausible, because if we're looking at high-intensity hospital settings, what patients and families are experiencing in the last 2 to 3 months of someone's life are repeated hospitalizations and a flurry of white coats around the bed, one specialist after another. In a teaching setting, one specialist with the residents and fellows, another specialist with their residents and fellows, coming by constantly, each one focused on a very specific area of concern, very seldom getting a coherent picture, providing a coherent picture to the patient and the family. What do physicians report? Difficulty arranging elective admissions, difficulty getting specialty referrals. Importantly, I think, difficulty maintaining good doctor-patient relationships. And I want to emphasize there what Dr. Taylor was saying, and I'll try to make the case as we go further into this talk. Doctor-patient relationships are crucial when there are many treatments. We can keep treating people, and routinely do keep treating people, thumping their bodies till their bodies finally give up. So the quality of the relationship is crucial, the strength of it, in helping people find a balance between comfort, function, and longevity. The chair, in other words, is a great, and an ear are wonderful pieces of therapeutic equipment. So how does palliative care work? Well, let's consider what people die from. The hospice model arose around cancer, and a little later when AIDS came in the 80s, before retrovirals, antiretrovirals for AIDS. A quarter of people in the U.S. die of cancer. The balance die of, I've categorized them in these other trajectories, neurological, cardiopulmonary, metabolic and multisystem, and trauma. Some people only have 4 categories. The natural history of these disease clusters vary, so patients in one category experience patterns of crisis that differ from patients in another. Consequently, patients in different groups may experience late-life treatment plans, but most of our acute care hospitals are set up with a kind of one-size-fits-all approach. One of the, in a sense, it's hard to call it a blessing, but one of the realities that can be helpful with patients with cancer and that works in the kind of traditional hospice model is cancers, when they're advanced, have a predictable, the prognostic indicators are pretty good. So you can tell somebody with some precision, a life expectancy of less than 6 months. So it works for the way hospice is set up in terms of Medicare eligibility. In these other clusters, it doesn't work so well. We may have very good curves for 5-year mortality risk with advanced congestive heart failure, but it's very difficult to predict with any exacerbation of heart failure whether that's the final one. Consequently, patients in these fulminant conditions come to ERs, come to ICUs, and get the full court press. And what we find, it's not uncommon to find in the last 12 months of someone's life that they go on an agonizing shuttle between an exacerbation of a symptom to an ER, to an acute care, ICU, tuned up, discharged to skilled nursing, discharged back home, decompensate, go back, and do the shuttle. It's not uncommon to say this is the 8th Virginia Mason admission, this is the 8th UW admission for Mrs. So-and-so in the last 12 months. This just gives some indications of how palliative care differs from hospice. And just basic information on hospice. One of the challenges, though, is that many patients, particularly with these non-cancer diagnoses, they end up coming to hospice. Everyone in the U.S. now understands what hospice is. They come to hospice in the last 3 days of their life, the last 2 days, the last 4 days, the last week, versus having a discussion much earlier when their disease course starts in a final trajectory of looking at how they want to live, how they want to balance comfort, function, and longevity. For the last couple years, I've been working with a group of people and the American College of Surgeons to develop a curriculum in palliative care to be used training surgical residents throughout the United States. So I say that a little hesitantly, standing in a room full of internists, when you see the word surgeon on this, but it's a very adaptable curriculum. The portions that are apply strictly to surgery are things that surgeons often have to deal with. Surgeons provide care for about 30% of patients as their primary docs in end of life, but often these are patients with malignant bowel obstruction, things like that, which are more narrowly surgical concerns. That's what it looks like. It's available for free in a PDF download from Kniff Dixon Foundation. I can provide that information for those who want it. And the ACS is willing to send the books for free to those who want them. So I want to talk a little bit about the table of contents of this book because we spent some time about it. When you look beyond the principles, the first chapter is personal awareness, self-care, and call it the physician-patient relationship. And the reason we put it first is it's not just about finding balance in your life, the challenges of being a doctor these days, and so forth. It is about being aware of one's own attitudes, thoughts, and feelings about terminal illness and about dying. Because what one finds so often is our own attitude about our role as physicians, our own attitudes, fears, and so forth about chronic illness and about dying affect how we shape the judgments we offer our patients. So we very self-consciously put that first, and then we looked at the things that residents are most typically asked to respond to. So-and-so in bed, 10, is in pain, do something. So-and-so short of breath, do something. So that's how the symptom management chapters ran. There are chapters on communication, for instance, 16, how to conduct a family conference, 17, how to discuss DNRs, and so forth. I want to go through with you briefly one chapter. Each chapter has pre- and post-tests, case examples, and so forth. So they've been designed to meet core competencies in every specialty in the U.S. But the cross-cultural issue, I think, is quite important. It's important in almost every city of the country, even places that we think of as kind of homogenous. North Carolina, for example, it has one of the fastest growing Hispanic populations in the U.S. So if you're in a small town in North Carolina, you'll find that 10% of your patients don't speak English as a primary language. Now, Seattle's a port. You're used to having people from all over the world all the time. So I expect in your hospitals you have people speaking, interpreters for 40 or 50 different languages. I trained at San Francisco General, and even in the 70s, it was, we had people from everywhere, and English was the primary language for probably 70% of them. So it was a very interesting time and place to practice. Each of us engages patients and families in a variety of end-of-life situations, and we encounter these cross-cultural differences. And I think it's important to remember that our culture, our internal culture, you can say the level of all of medicine compared to the public. You can say the culture of medicine compared to the culture of surgery. Our cultures and subcultures are different also. So we're constantly talking cross-culturally. And our encounters can go well or poorly depending on our knowledge, attitudes, and skills. When anthropologists talk about culture, they talk about it, they have kind of 4 theoretical constructs. But I want to focus on the one that we're using in this book that I think is most useful in working with patients, what's called the explanatory model. It was first devised by Arthur Kleinman, an anthropologist and physician, whom I've worked with pretty closely over my career. And it involves learning what the family and the patient, how they explain things. So it's a series of guided questions. What? What do you, meaning the patient, call the problem? Somebody might say, I have a tumor. Now, they might not understand that tumor means cancer. You know, very basic. You won't know unless you ask them. So what we want to avoid is talking past people or listening past people. And when we look at doctor-patient interviews, even when we're in our active listening mode, people who observe that find, well, the docs talk about 3/4 of the time anyway. But again, the chair and ears are very helpful to listen. Just ask open-ended questions. What do you think? How do you think this behaves? What do you think it's going to do? And crucially, what do you fear? Because fear is the flip of hope, the other side of hope. If you know what they fear, one can start crafting hopes that are realistic given their likely prognostic path. Why? Why do you think it occurred? You may be surprised by answers that come out, because something that seems to you remote or even silly may be a matter of the patient. And it may be, if they think it occurred because of something they did, a sin of omission or commission, if you will, they may think that they should be suffering. I mean, that's just one possibility. How do you think it should be treated? Who should they turn to for help? Who should be involved in the care and decision-making? I've had one situation where the key decider, it was a patient in the South. They were fervently religious in a fundamentalist, a born-again faith tradition, and they would only discuss things that really mattered to them if their pastor were present. Otherwise, clam up and no discussion. So finding out who should be involved can be very helpful. When one's talking about end-of-life situations, often it's the norm in some situations, in some cultures, not to discuss death directly, especially a specific person's death. So one has to talk around that by asking questions. Also, in many communities, communal decision-making is common, particularly in some of the South Asian communities that have had heavy immigration since the Vietnam War. An elder is involved to make the decision. But in other cultures, the physician, they have very differential patterns. The physician is the person who's to decide. So in America, when we say, well, we're here really to help your autonomy, you tell us we can do all these things, here's a kind of takeout menu, what would you like us to do? They look at you as though you're speaking insensibly. They don't understand that because they're used to physicians telling patients what to do. And this is not something that happens in cultures exotic to Euro-Americans, but it's a common pattern for patients coming from Russia, for instance, patients from Eastern Europe, patients in France. They have a more deferential pattern. So finding out how they imagine decisions being made is very useful. What is the goal of all this? The goal is to, as I've tried to talk you through in this presentation, what we're doing now is not doing anything for longevity on a population basis. If it were, the U.S. would be 20% above everyone else in the world in average life expectancy. In fact, we rank about 25th, I think. We're around Costa Rica in average life expectancy. In this country, and according to the Washington Post, life expectancy for women in states in the South at the moment, and this economic contraction is falling for the first time in recorded history in the U.S. So what are we trying to do? We're trying to balance for individuals and families comfort, function, and longevity. Abstract terms, but they're kind of three general categories of goals of care. And by focusing the discussion on what matters in terms of function, what would they like to do, what would they like to be able to do, they may want to get to a granddaughter's high school graduation. They may want, how can that happen? Is that it's 6 months off? Is that realistic? But you're focusing on how patients would like to live rather than if they would like to live or how they would like to die. One of the challenges of moving into a palliative world is, at the moment, we have a model where everything is done, everything, and then the body's fading and we say it's time for hospice. So it's kind of on and then off and hospice, boom, you're dead. And that's why people often delay hospice till they are absolutely, frantically compromised. This is trying to insert earlier in the path in the natural history of the problem this idea of how one would like to live, how to balance various aspects of living. What are some conversational strategies? This book walks one through learning these skills of just how to talk with people. It's very useful to say, well, I'm not really asking you, but I would like to know how things are done in your world. It's important not to use a family member as an interpreter. For example, but to go back to how things are working in your world, this gives an example. I don't know much about how things, I don't know East India, I haven't been there. I don't know how things work there. Would you tell me? How do you understand? Tell me. Always it's important to start out with a statement of respect and a desire to learn. Remember, there's a vast social distance between physicians and most patients, particularly when one's working. I've spent most of my career working with poor, uneducated people, and the social distance, as they perceive it, is dramatic. That can be a great inhibitor in these kinds of conversations. So saying respect not in a soppy way and curiosity go a long way in brokering this social distance. What happens when people, this is pretty common, don't tell the patient she has cancer, she has terminal congestive failure, etc., terminal liver failure, end-stage renal disease, and so forth. Don't tell her. It's very common. How do we get through this? Because being in our system, saying you're not going to tell somebody violates all the bioethics training that's been drilled into us since 1970. So, first of all, the respect statement. Thank you for letting me know. Somebody's saying, don't tell grandma. But you want to start finding a way to be true to yourself and work with the patient and the family. So asking them, why do you want to handle it? Why do you want to do it this way? What would happen if I talked directly with the patient? So here are some suggested steps. First of all, to remember one's own values and the system we work in, and basically let the patient know, here's where I'm coming from. In this country, we use a fancy word, autonomy, but what it means is, in these kinds of conversations, we think patients who are clear-thinking should make their own decisions. So that's our system, and I need to tell the truth to feel good about myself. And you can propose a negotiated approach. I can hear you, I hear what you're saying, and I know where you're coming from. Let's try this. Let me talk with your grandmother and explain that you and I have talked and that you're proposing that she leave all the details to you, and I need to check that that's okay. Now, I'm describing a series of conversations. I also want to recommend that all of this be written in a chart. It means nothing, as you know, if it's not written down. And this is particularly important in these kinds of settings because the world runs 24/7. There's a day shift, an evening shift, and a night shift of nurses. If the communication is not clear and the family is divided, or there's this non-disclosure situation and you've reached a deal and it's not written down, the unity of the message, the unity of the approach can fracture. And when that happens, it means that then no decisions are made. The patient keeps getting lots of intensive diagnostic and therapeutic interventions that he or she may not really want, and that may not be may be futile from a kind of medical point of view. It's important always to set ground rules. If we'll do this, but if Grandma changes her mind, I'm not going to lie. Do you understand and agree to this? So it means talking and listening, and then you can come to an agreement on it. So I'm using that as just an example of what palliative care curriculum, the kinds of skills that training are involved. The book has sample scripts because it's often tricky and uncomfortable for us to have these conversations, particularly when we haven't done them before. So what palliative care can do? Well, I would argue whether we call it palliative care or good doctoring for patients near the end of life, that's a mouthful, but I think that is what is involved. I would love to see, I've spent a good bit of my career chairing departments of bioethics in medical centers. And I'm always tried to resist when they say, well, palliative care and end-of-life care it belongs with the ethics committee. I think it belongs in clinical training because I think it's part about being doctoring. And as evidence for that, I would say, Art Kaplan at Penn agrees with me. If you look at the nuts and bolts of cases that come to an ethics committee, 10% involve some ethical dilemma. The other 90% are examples of communication gone awry. Well, good doctoring in end-of-life situations, in addition to technical skill, is all about communication. So, what can it do? Relieve patients' suffering and those of their caregivers as their lives wind down. If somebody's dying, several surgeons have said this to me, if somebody's dying near the end of life, they won't go after you because you operated on them and it didn't cure their disease. They may not go after you anyway. What I get thank you notes for patients who have died is, these are surgeons talking, thank you, you provided exquisite care to my mother, grandmother, grandfather, and so forth. You were there for us. The same applies in medicine. You assist overwhelmed family caregivers. That's what they remember. And it's important to remember their lives go on. And if they've had a horrible end-of-life experience with somebody close to them, it is equivalent stress to people who've gone through other significant stress. They start experiencing symptoms of post-traumatic stress disorder. So improve communication between patients and doctors and physicians. And the health economists love the potential of this because they say it lessens extreme overuse and misuse of medical resources. And I'm not trying to gainsay that. I'm saying I'm here today speaking as just a physician who's trying to argue that our basis with society, we're not the health planners, we are active in society trying to use our sound judgments to help prevent and ameliorate suffering. I'd like to close with a poem written by somebody who's become a friend, who's often in Seattle at Elliott Bay. He wrote a novel called Legends of the Fall, which was made into a movie. That's how many of you may know him. His name's Jim Harrison. We grew up near each other. And the poem speaks for itself. And I think I'll stop here, and we have some time. Thank you.
Thank you so much. We have time for questions. We have microphones on both sides. And I would, please, let's start.
I always have at least one, but I could spend a lot of time. I'm Bill Hazard from Geriatrics. But I think our challenges are quite similar. And I'd be interested in one particular perception. I heard you were being introduced as from the NIH.
Yeah.
And I can't imagine a more difficult cultural divide to bridge than doing what you're doing at the NIH. Would you share that with us, your experience?
Well, what I do at the NIH is not what I'm talking about today. What I do, actually, my own research interest at the moment is, it's from the kind of history, social science, humanities side of my life. And I'm very interested in what's called translational medicine. So in fact, I had a paper published yesterday, which I haven't had a chance to see yet. But I'm interested in this new area, seemingly new, so-called new area of translational medicine in my own. And then I have a group of 8 postdocs who are looking at things like the history of human subject protection, nanotechnology, how groups get together to set standards, how they negotiate things politically. Another is looking at the development of the risk factor and the debates over the relationship of diet, cholesterol, and heart disease, and the fact that we do a great deal of interventions. It's a huge pharmaceutical profit maker on a rather shaky scientific foundation. So I oversee this group of kind of ambitious postdocs. The NIH has a lot of them. And then we have an extensive archive and a museum. So that's all part of my NIH job. I work for Kniff Dixon Foundation as a consultant. It's an approved outside activity at NIH. So that's how I got involved in surgical palliative care.
Other questions? Dave? Dr. Curtis?
I wonder whether you have some thoughts about the historical trends around advanced directives, what you might consider the rise and fall and now resurrection of advanced directives and advanced care planning as one aspect of this. It seems like we really have gone through a lot of particularly within academic medicine, through these very dramatic swings on whether these are useful and helpful and should be a core part of what we do.
Yes, I'll make a few comments, and perhaps you would too. One thing to remember is the laws governing advanced directives are at the state level. I'm very aware of this living in Washington, D.C., because we're surrounded by Virginia, Maryland, and D.C. They each have different rules, for instance, on what paramedics do in the field. In New York, where I've also been active in New York City, obviously people work in New Jersey, Connecticut, New York. They all have different laws. So so there are slight differences. In terms of historical trends, they came in the same way elaborate informed consent documents came in. And so the advanced directives can start resembling, they can be very lengthy in some settings, just like informed consent documents. When they came in, there was a great optimism. You do this, people are informed, people have made their choices. And of course, in any bureaucracy, process quickly gets reduced to paper. So there's this sense, have they been consented? Do you have a DNR? As though the paper, if I had a sheet of paper here, I don't, but I hold this up. Yeah, they have. Well, it's a piece of paper, and what stands behind it is a process. And often, and handing somebody the paper when they're admitted to the hospital and saying, here, look at this and consider it and sign it and give it back, is not a process. And that's been a huge challenge. I think a lot has followed from that. Healthcare powers of attorney, where you designate a surrogate, are used widely, and there's a great regional variation in their take-up, how they're used. There's a huge variation in whether they're ever honored, any of this stuff. Because in many settings, and I can speak because both my parents have died in the last few years, if we were telling stories today, I could tell you the adventures of both of them had extensive end-of-life planning in paper because they'd spent a lot of time on the process. They were quite reflective about it. Nonetheless, it was only by luck that anybody honored them. And in my mother's case, she had an extensive, she died a year ago, a DNR, and you can do this and do not. Nonetheless, when her condition was deteriorating, they were ready to put in a permanent pacemaker. One of the challenges, and I'm mentioning that because one of the challenges is you can't, as you know, taking care of patients who are sick and unstable, it's a very dynamic process, and things happen that you don't anticipate. And the DNR has this kind of false rationality of things will unfold in a certain way, and therefore it will be very clear to everybody, we're going to do this, we're not going to do that. But you find people saying, well, yeah, if that happens, you can start my heart, but not if this, or, these partial things. So, historically, this optimism will create this administrative structure, and that'll handle it, which degenerates into, have you signed the paper? Do you have it? And then the vagaries of late-stage illness and our forms and our processes haven't quite captured that. That would be 2 points I'd make on that.
Any other questions?
Ma'am?
Thank you for a wonderful talk. I like to think about the phrase, death ends a life but not a relationship. And what happens is the patient will die, your patient will die, but the family will still have an ongoing relationship with that patient. It will reflect long, for many years, on the nature of the process around that patient's dying and your, the physician's conversation with them. I'm an oncologist, and we do try in our clinic to have these conversations over a period of time. And one challenge that we face is that we've had conversations over 6 months with somebody with advanced lung cancer, and then they come into the emergency room and they're asked, shall we do everything for you? And then, even though we've had many conversations and a plan, plans change, even though the underlying process, the medical process hasn't changed. And how can we best address that as a system?
Plans change. Even one of the chapters in the book, A Life Worth Living, I write about a colleague who's in his 40s, somebody I knew very well, although I've disguised his identity in the book, who developed esophageal cancer. And he wasn't wide-eyed about American medicine, and he wasn't wide-eyed about his disease. So he initially underwent pretty aggressive surgery, and then he said, maybe I have 3 years, and he went for a couple years, and he said, I don't want any scans. I'm just going to concentrate on living. And I'm getting to the point, near the end, he was having metastases in his brain, and he changed. He said, okay, I'm going to go in for radiation, to shrink him. And afterwards, he said, because the radiation kind of wiped him out for a while, he said, why did I do that? In other words, people do change. The second piece is that in our hospitals, we typically frame everything as something that's in technical terms. We assume that our care for patients in the broadest sense is providing more technical aggressive interventions. So when somebody comes into the ER, and if they can say, it's usually their spouse or partner or somebody saying, and we say, well, do you want us to do everything? Versus we can, imagine a lung cancer patient might have problem breathing. There are levels of how we can support ventilation. We can make Mr. So-and-so comfortable. We can do that. We can intubate the patient. We can put them on a ventilator, artificially support their lung function for a time. But instead we say, do you want life support? Our forms say, do you want life support, or should we stop life support? And that goes along with the everything. And then when they say, to say no to that, well, do you want us to stop doing everything? As though stopping these techno-interventions is stopping everything. When stopping everything, what patients and families most upsets them is when they're abandoned. So if we say stopping everything, meaning they interpret it as, are you abandoning me? that's when they give way to despair. So it's bridging that, and I don't know in UW, but in a lot of hospitals, when you look at the language of end-of-life materials, it will talk about life support. Do you want us to stop life support? Versus artificial support of your lung function, artificial maintenance of your kidney function. Artifice is a wonderful thing, but those things are designed as bridges. If they're bridges to nowhere, if they're just extending dying, if we had our language reasonably honest and less these kind of hollow euphemisms, I think we'd be ahead of the game. One point, you don't see it so much with cancer patients because they die younger, but a lot of what I'm saying, patients over 75, this work of palliative care is disproportionately for women, older women, because women outlive men 5 to 8 years. In other words, when men are alive, many of them have partners to speak for them. When you look at the admissions coming from skilled nursing facilities, people on this agonizing shuttle, it's a disproportionately older single woman group. They have kids, some of them, so you have to be very involved in family dynamics. Some of them don't have children. If they don't, they're on the default model of the system. That means they get thumped, they have more shuttle time. In a sense, they suffer more. So being able to be proactive in addressing how to reach these women and think through is a major challenge, I think, for palliative care and for institutions on a systemic basis. I'm sliding that into your question, just I thank you for letting me do it.
Dr. Farber.
Hi, I'm Stu Farber, and I'm the director of the Palliative Care Service here, and I know many of you. And first, I want to thank Dr. Martensen for his excellent talk, but also I want to thank all of you because I think that we at UWMC really are much farther down the road of this kind of conversation and communication and this kind of balance. And our service certainly looks forward to continuing to work with all of you to continue to promote the ideas that Dr. Martensen is sharing, but I think that we're all committed to. So thank you all as well.
And in conclusion, thank you all so much, and appreciation on behalf of Group Health and the University of Washington Partnership. Thank you again, Dr. Martensen.